I'm here to introduce Colonel Stacy Shackelford. Stacy is a trauma medical director with the Defense Health Agency, and she's currently resides in Colorado Springs. You may know her from her previous work where she was the chief of the Joint Trauma System, which is the most influential position for a trauma surgeon in the DoD. She was previously in San Antonio, now, like I mentioned, is in Colorado Springs. While she was the Joint Trauma System Chief, she's developed a systematic process for organizing our trauma services for both the pre-hospital in-route care and as well as in surgical facilities. And so she's really done an incredible job at trying to hone a lot of these things that we're talking about down to make it easier and more available for surgeons, medics, paramedics, nurses, everybody in the field to access care. So thank you, Dr. Shackelford.
All right, I've seen a lot of people struggling with remote here, so let me see if I can do it. Yes, on the first try. Okay, first off, just a brief disclaimer. According to the DoD, I speak only for myself, and I do have no conflicts of interest, although I always like to disclose that I do have an interest in conflicts. I did also at the last minute read the instructions, and so I did make an attempt to write the learning objectives here. And also, we are going to really focus on the ideal future state, which was part of the directives, not all the challenges we've encountered in trying to implement. So quick poll. If your hospital has a guideline for damage control resuscitation, also known as balanced resuscitation, or a guidance for implementing this in trauma patients, raise your hands. Okay, I think that's maybe about half the folks here. It's just kind of make you think about why lessons learned from the military are important. Even a little more challenging to implement, does your hospital's trauma system have you implemented pre-hospital transfusion for trauma patients? Okay, wow, probably 30%, 25, 30%. Okay, cool. All right, so the Joint Trauma System evolved starting in 2005. So we also say that we have never gone to war with the trauma system until even in the current conflicts, we started without a trauma system. And it's really lessons learned from the civilian sector that inspired us to implement a trauma registry and a trauma system in the deployed environment. So for this, we have a lot of thanks going to the civilian trauma systems. The vision, each of our organizations has a mission and a vision statement similar to on the civilian side. But I think one thing that distinguishes the military is this: we have a very, very close connection with our role in the mission. And I would say that our mission is not necessarily to deliver healthcare; it's to support the mission of the military in multiple environments. And in that way, we're really facilitating the mission in our delivery of healthcare. But this close connection to the mission has really inspired us to try to improve the trauma care. This diagram here represents the operational cycle of the trauma system. And you can also think of it as a way to describe the learning healthcare system or the learning trauma system. And it starts in the top center with trauma care delivery. As you deliver trauma care, you're going to document that trauma care, and that will turn into data that's abstracted into the trauma registry, similar to the civilian system. That generates data that can be analyzed for the purposes of performance improvement, and then feeding back into best practice guidelines, which will then guide us into the trauma care delivery of the future as a continuously evolving and continuously learning process. In the Joint Trauma System, our trauma care is delivered according to the roles of care. I think most people in this room have had some familiarity with this, but it does have a very strong correlation with the civilian environments as well. And I think it's important to recognize that the guidelines that we develop are specific to the roles of care. And so there's not a single guideline that applies across the board, but there are general principles that apply, such as damage control resuscitation, that could be implemented in the pre-hospital and first responder environment. There's different guidelines as that's implemented in the hospitals and in going on to definitive care and rehabilitation. Different guidelines are needed for all those environments. However, they should be closely connected. Some of the specific mechanisms that the Joint Trauma System has used to implement performance improvements is, of course, the trauma registry and the collection of data. I think there is a lot of expert opinions all over the place. And, we have a very formal rank structure within the military. And so it can be hard to express your recommendations if you're just solely relying on expert opinion. And if you fall back on data and you have the data to support your recommendations truly, truly go much farther. The video teleconference communications that we've developed in the trauma system and the military really span the roles of care and multiple continents. And so I've not really seen this equivalent on the civilian side, whereas we review the sickest patients that are cared for each week and connect the pre-hospital providers to the initial stabilization hospital, to the en route care providers, and the final facility where they were hospitalized. This sort of collaborative discussion of every serious case has really contributed into feeding back into our lessons learned and our guideline developments. Analysis for the purposes of performance improvement. A lot of this is based on the registry. In the military, we really don't do a lot of prospective randomized controlled research, although we do fund it on the civilian side, but we rely heavily on analysis of retrospective data to feed into our clinical practice guidelines. I wanted to highlight this simple chart because it was, number one, it was the first performance improvement project that was done formally in Iraq. And essentially what they did is they noticed there was a lot of hypothermic patients coming into the hospital, and they just tracked temperature on arrival to the hospital, put it on a dashboard, and made it visible to a lot of all levels of care and leadership, and just making people aware of the problem, showing that that we are tracking this and we're paying attention to this. It results in improvement over time. One of our earlier attempts to analyze the impact of the clinical practice guidelines was in 2009, a publication that came out in the American Journal of Surgery, looking at three of our earliest clinical practice guidelines. One was the burn resuscitation guideline, showing mortality from abdominal compartment syndrome decreasing from 36 to 18%, hypothermia on arrival to the hospital from 7 to 1%, and the massive transfusion, the mortality of patients who received a massive transfusion of 10 or more units in the first 24 hours, that decreased from 32 to 20%. So this was kind of just early efforts to really look at, were our guidelines having any type of impact? I would say that this has evolved quite a bit, and I'm going to go show a little bit about our dashboards here shortly. Two of the main websites that we use to share information are also very essential to our success. One is jts.health.mil, and the other one is deployedmedicine.com. Deployed Medicine is also an app that you can put on your phone. These websites are visible and accessible to anyone. We've made a big effort to make them accessible even from like Ukraine or all around the world, and to anybody and everybody, even though it's the JTS one is hosted on a .mil website. It's exclusively allowed easy access. You can also see on the top the link to the advisor line, which is our telemedicine consult system. So you can easily access that to provide telemedicine. The phone application has all the guidelines formatted in a way that are also easily viewable on your mobile device. For those of you who have your phones out right now, feel free to download the Deployed Medicine app onto your phone if you want to look at it right now. The Defense Committees on Trauma. This has been also a huge importance to the evolution of our guidelines. Each of these committees focuses on a particular environment, either the tactical environment, which is our pre-hospital team, the surgical teams, which may involve the sort of rural damage control resuscitation equivalents, or our more definitive roles of care, and then the en route care environment. And we have made a pretty big effort to represent all services, all types of stakeholders in each of these committees so that we get a balanced perspective as we develop our guidelines. Working with our implementation science folks at the Defense Health Agency, we also looked at some ways to really help get that information out there, simplify that information into little snippets. They recommended putting these signs up in the toilets so people could read them while they're using the bathroom, and just to really kind of facilitate getting that information out there. Hard to quantify what effect that had. Also on the implementation science side, this is just an example of how logistics plays such an important role. And about 10 years ago, when we first started implementing TXA in our damage control resuscitation protocol, you can see just reaching out to every single deployed surgical team and just simply asking them, do you have TXA on hand or not? And then trying to figure out if they didn't have it, how to get it to them. So tracking compliance, I think, gets into really the nuts and bolts of how the trauma system functions. And in recent years, we have invested heavily in bringing on board the data scientists who can really help facilitate collecting and viewing our data. For many years, we curated this awesome registry that contained a lot of data. And if you submitted to an IRB, arduously, eventually you could get access to the data. But we've really made an effort to make that data accessible right now on these dashboards, and really developing the metrics for each of the guidelines and collecting the data in an automated way, trying to bring that data into the system, from the electronic health record to the registry automatically so that someone doesn't have to physically review it, is really part of the solution, and heavily invested in that IT groundwork. The Walker dip is a concept that's really spurs us to sustain and develop our processes for the next conflict. As you can see, this idea shows that our experience, knowledge, and expertise peaks during the conflict period and then bottoms out during the inter-conflict times. And right now, we're sort of in that bottoming out time frame. And we hope that by implementing these type of best practice guidelines, training programs, and collecting lessons learned and experience, that we can mitigate that dip before the next conflict, which really we don't know when that could be. It could be next year, it could be decades from now. So in summary, I'm just going to kind of try to think about which of the military lessons learned could have an impact on the civilian side. Learn from the past, prepare for the future. This sounds sort of obvious, but you have to really kind of have a formal method of collecting those lessons learned, analyzing them, storing them, and applying them to the future situation, which most likely is not going to be the same as the current situation. Commitment to the mission. I know we're all committed, and I think, just having that extra involvement in the military mission is a motivator for us. And I think, trying to find where that is on the civilian side is incredibly important. Focus empiricism. This is something I learned from Todd Rasmussen when he was the director of the Combat Casualty Care Research Program. And this means like, we don't need a randomized controlled trial for everything. Like, have you ever seen that article on from the British Military Journal about randomized controlled trial of parachute use? You know, like, so crazy to think that we can't get stuff done unless there's randomized controlled trial. And so on the military side, some of this, it's really been this commitment to the mission that has facilitated us implementing things like whole blood, and, damage control resuscitation, 1-to-1-to-1, all of this before we really truly had the evidence. And then not just, irresponsibly forging forward, but to collect evidence, continuously analyze it as you go to allow you to modify your direction if you need to. Continuum of care conference, I mentioned this previously, but I think every hospital, civilian hospital I've worked at, we never have a all overarching conference where we, go outside our own silos and connect with just based on the patient. Role of care specific guidelines. This kind of speaks to having, separate guidelines, if a separate portion of the guidelines, maybe that applies to the rural hospitals or the pediatric facilities, et cetera, different environments, pre-hospital. Pragmatic guideline update process. It can't take, such a heavy lift to update the guidelines that they're 10 years out of date. Expert committees are so important to us. There are a lot of committees on the civilian side, but I think the challenge we're running across on the civilian side is having like sort of parallel efforts, or the Eastern trauma and the AAC and the Western trauma. And it's hard to know like who's really in charge here. Maybe it's American College of Surgeons, we're here at their building. Then second to last, recognize people for doing their job. We have all these ribbons, like just show up to work every day. After a while, you're gonna get a reward. It doesn't have to be like something like crazy and out of this world. Recognize the folks who really doing their job, and keep the doctrine up to date. Doctrine is kind of an arduous process to update. I'm not entirely sure what the civilian equivalent is, but this tells us how we fight, how we go to war, how we lay down our hospitals. And it's such an arduous process to update it that often we kind of like don't take the initiative, and we try to work around the doctrine and come up with non-doctrinal solutions. And really, we're the ones that write the doctrine in the first place. We should really just change the doctrine so that we can get the funding and the equipment and the support and the teams built all around to the same endpoint. So really fight those hard fights and make sure you get to the end state that we're looking for. And with that, that's a summary of lessons learned, and be happy to answer any questions.